Hey, this is Joe Hartman with intraoperative and Sentient Medical. This is the third video in the series, and this is the one where we're going to go over lower extremity SSEPs as well as some of the components of the equipment. So let's talk about the lower extremity. Again, like the upper extremity and all modalities that we have, we need to be able to take this list and insert the numbers that are appropriate according to the ASNM and ACNS guidelines, because those are questions that they just love to put on an exam. So the number of trials is 250 to 1,000 for the ACNS, 500 to 2,000 for the ASNM. The analysis time is a bit longer than the upper extremity. It's 75 to 150 to the ACNS and 100 for the ASNM. If I had to pick a number on the test, I would put 100 for there. Pulse width is the same as the uppers, 100 to 300. Stim rate is similar to the uppers also, or 2 to 8 stimulations per second. Not an integer of 60, not an even number, and 2 to 5 from the ASNM. Remember, the lower extremities are a little bit more prone to amplitude degradation with an increased rep rate, so we need to stay below 5, even though the ACNS has it all the way up to 8. Stimulation intensity, again, similar to uppers. The general range of 30 to 40 milliamps is given, up to 100 if needed. Till the pop fossa amplitude no longer increases in size. That's the same rationale behind the Erb's point. Stimulation intensity twice motor threshold, which is around 6 to 10 milliamps, again, similar to the upper extremity. Impedance is also the same, less than 5 kiloohms for both stimulating and recording electrodes. Again, we're using a monophasic rectangular pulse. Bandpass is 30 Hz to 1000 kilohertz with a -3 decibel amplitude slope. The low cut is 30 Hz and the high cut is 1000 for the ACNS. Bandpass for the ASNM is 30 to 100 Hz and 250 to 3000 Hz for corticals, and 30 to 100 Hz for the low cut to 1000 to 3000 Hz for the subcortical. Surgeries below C8 nerve root level can be monitored with posterior tibial nerve or common peroneal nerve. So that is the ASNM guidelines as to when you should be using posterior tibial nerve SSEPs. Notch filter is off, and we'll get into notch filter a little bit later as to why we keep that off, and interleaving potentials to increase recording time. Stimulating electrodes at the posterior tibial nerve, which goes up the sacral plexus or lumbosacral plexus from the roots of L4 to S3. The ideal stimulation site is posterior to and slightly above the level of the malleolus, so as to stimulate both the medial and lateral plantar terminal branches. If you stimulate too distally, you may catch only one terminal branch. So if we look at our little drawing here, or even the anatomical drawing, we can see it branches out just distal to that medial malleolus. So if you have your stimulation site over here, you have a better chance of not getting every axon. So we want to stick it up where we have that nice meaty nerve located still very superficial. You may have poor evoked potentials if the patient has polyneuropathies like diabetes or hypothyroidism. The anode is located 3 centimeters distal to the cathode, just like every other stimulation for SSEPs. And the motor responses be a toe and ankle flexion. If we stimulate the peroneal nerve, the lumbosacral roots covered would be L4 to S2. It runs superficial over the fibula, immediately distal to the fibular head, which is just distal to the lateral knee. Stimulation there produces dorsiflexion of the ankle, may cause excessive movement during lumbar surgeries. So that is the downside of using this response when we can't get one from the PTN. And when you stimulate it, especially when muscle relaxant is wearing off during exposure, make sure that you peek up at the bed and make sure that leg is not flapping all over the place. If so, you have to run it judiciously or try to find that sweet spot where you are at that threshold level and not a ridiculous super maximal intensity. The anode is located 3 centimeters distal to the cathode, like always. Can also stimulate with anode above the fibular head and the cathode medial to the long head of the biceps femoris. Again, that's an anatomical location with a muscle, so remember that muscle for the exam. Peroneal stimulation may produce on average a smaller cortical evoked potential due to smaller somatotopical representation in the cortex, and it's useful when PTN is unreliable. So here's our pictures of where we would put our anode and cathode being black, being more rostrally placed. Lumbar sacral plexus. The blood supply to the lumbar and sacral plexus usually derives from branches of the internal iliac artery, which has the iliolumbar artery, the superior and inferior gluteal artery, the lateral sacral artery, and the deep iliac circumflex artery. So this is the vascular supply of this lumbar sacral plexus. And while we're on this picture here, I should also note, if you look on one of the article posts on my blog, I go into saphenous nerve stimulation, which can be useful in certain procedures like X-lifts. So that is another stimulation site, and if you have an above the knee amputation, again, that might be a go-to area to stimulate. Also causes a lot of muscle or muscle twitching because you have to stimulate at a pretty high level at a pretty long pulse width in order to get something replicating. Cauda equina. There's terms on this page that you just need to know for the exam. So both the lateral sacral and iliolumbar arteries, which originate from the internal iliac artery, send small branches into the anterior sacral foramen to supply the cauda equina. So the cauda equina is the horse's tail. This is all those end of the lumbar and the sacral roots that are being splayed out at the very end of the spinal cord. The end of the spinal cord is called the conus medullaris. That's important to know the difference between the two. They seem to always ask a question where both of those are an answer to, what's the end of the spinal cord called or what's the horse's tail called. And since they both start with the letter C, a lot of people mix those up. Be familiar with where the spinal cord ends. Do not get tricked on something where they say the spinal cord's at L4. Typically it ends up in the lower thoracic beginning of the lumbar L1 area. And then the last term is the filum terminale. This is the ligament that connects the spinal cord down to your sacral area. This is the one that they cut in the tethered cord cases. It's the one that we stimulate in those tethered cord cases to differentiate the ligament from the actual nerve roots. Since that is since that's a case type that we do in a large amount in the pediatric setting, it's highly probable that test or that answer or that question is somewhere in the test bank. Lower extremity SSEP pathways. So we have to be able to know the entire pathway from stimulating to the end recording of the cortical area. So when we stimulate the PTN or Bandpass or saphenous nerve, it runs up that peripheral nerve up through that lumbar sacral plexus and has the first order neuron is in the dorsal root ganglion, comes up the synapses in the dorsal horn, comes up the dorsal column in the very medial section, all the way up to the brainstem where it decussates at the cervical medullary junction. At the point of decussation, now which was medial in the spinal cord dorsal column becomes lateral to the upper extremity within the brainstem. So the easiest way to remember this for me is I take both hands out in front of me and I do the peace sign with my palms facing away. Your two index fingers are your lower extremity portions of the dorsal column, and your two middle fingers are dorsal column representative of the upper extremity. When you get to that cervical medullary junction, you just cross hands, and then now you see both your index fingers are a lateral portion, so now you're in the medial lemniscus. And then once you get up into that internal capsule, it now rotates. So now your palms are facing towards you, and your two index fingers are now medial again, and then that goes to the medial cortex, where the middle fingers or the upper extremity goes to more lateral areas of the parietal cortex. So here's just another anatomical picture where it shows the pathway from the lower extremity as well as the thoracic area going to the cervical medullary junction, transitioning to the contralateral side, twisting once it's in the internal capsule, and then synapsing at the cortex. Lower extremity generator points. The pop fossa is a traveling propagated potential recorded in the popliteal fossa or the posterior knee. The lumbar potential, this is something that they use in diagnostic SSEPs, but we do not use it in the OR, mainly because it'd be right smack in the middle of surgery. But the lumbar potential is a stationary, non-propagated lumbar potential recorded referentially over the dorsal lower thoracic and upper lumbar spines, reflecting mainly postsynaptic activity in the lumbar cord. So this is very analogous to our cervical response. It's when the dorsal root enters into the tip or the conus medullaris of the spinal cord, synapsing on the gray matter dorsal horn. Your active electrode is classically over the T2 spinous process, but you may find better signals in some people if they have a lower placed spinal cord and say around L1, or it might be better at T11. Again, this is not something that we typically record. The N34 is a subcortical generated far field potential. It is recorded referentially from the FPZ electrode and is most likely analogous to the N18 following median nerve stimulation. It probably reflects postsynaptic activity from multiple generator sources in the brainstem and perhaps the thalamus. N34 is preceded by the small positivity or the P31, most likely analogous to the P14 of the median nerve stimulation. And over here we have the montage references and the amplitudes of the waves that are representative. Sorry, I was checking my phone. Representative of the amplitudes here. Lower extremity generator points. P37 reflects activation of the primary cortical somatosensory receiving area. It is recorded using bipolar derivations to subtract widespread far field signals from the superimposed and topographically more restricted primary cortical activity. There is considerable variability in the scalp topographic distribution of the P37 response. It is usually maximal somewhere between the midline and the central parietal scalp locations ipsilateral to the stimulated leg. To avoid erroneous reporting of P37 as absent, it is necessary to record from both midline and ipsilateral scalp locations. So I think most people, if we looked at their program, they probably would have two cortical lower extremity SSEPs, one of them being that CPZ to FPZ or the midline area, and the other being an ipsilateral C3 or C4 or CP3, CP4 to the contralateral CP3, CP4, or maybe reference to the CZ, or possibly even to the FPZ. I personally have a minimum of 3 cortical channels that I use. Sometimes I have 4 up there if I'm not getting great responses, because I like to pick the response that's the most reliable to use. If you're only using one, you might be shortchanging yourself and missing out on opportunities to monitor cases where you might not be able to off that one channel. Popliteal fossa, into a little bit more depth. It's a triphasic compound nerve action potential recorded in response to tibial nerve stimulation. The latency is directly dependent on peripheral nerve conduction velocity and limb length. It typically comes around 7 to 9 milliseconds, sometimes a little bit shorter than that. High signal to noise ratio. The first electrode place is the negative 2 centimeters above the popliteal crease, and the second positive is placed midline 3 centimeters proximal to the first. So here we have it flipped. We're used to having the negative being more rostral and the positive more distal, where it's the opposite from a recording standpoint. Both orthodromic and antidromic action potentials are here. It's a near field traveling wave used to verify adequate stimulation. Just like the Erb's point, blood supplies the popliteal and posterior tibial arteries. It's not considered an obligate peak since not used in a diagnostic setting, but highly recommended in the OR. So the ACNS chooses to use the lumbar potential, where people in the operating room are more likely to use popliteal fossa. If we look at our diagram over here, we have pop fossa reference to the knee. We typically call this pop fossa negative to pop fossa positive. Here again, we have a spinal near field potential, where they're looking at the tip of the spinal cord down in the lumbar area. It just has a little bit different reference. They're using the umbilicus, where most people will use the iliac crest to get that lumbar potential. Here we have the subcortical frontal area reference to the cervical, and you have this nice positive or down negative area. I'm sorry, it's a positive wave at the P30, which is the same thing as P31. It's just called a little bit different here. And then here we have a cortical channel to a referenced ear, picking up some of these other far field potentials as well as the cortical potentials. So again, this diagram here has only one montage that might be familiar to you, where the rest are all a little bit different. If you have a picture up on your CNIM exam, make sure you start over at the left side and look to see where their active and references are. You need to ask yourself first, am I in the head? Am I in the neck? Where exactly on the body am I? Second question is this a bipolar or referential montage? If it's referential, meaning it's not next to each other, it's not head to head or neck to neck or something like that, then you need to start thinking about, I'm going to be looking for far field responses somewhere on this wave. If it's a bipolar, then you're thinking, all right, where is my close approximate generator to wherever it is? So if it's on the head and it's from the upper extremity, you need to start looking around that 20 millisecond latency area. If it's from the lower extremity, you need to start looking at that 40 millisecond. So I know that's a little overkill, but they will put some very grainy pictures up there that kind of distort what you're looking at. And so you got to kind of orient yourself and look at it from that perspective. The lumbar potential, the T12 to iliac crest, not a standard for IOM, may be used when problems with pop fossa in the thoracic or cervical procedures. It is a biphasic wave. Absolute latency is in the range of 18 to 25 milliseconds. It's a stationary potential, but does have a lower amplitude traveling wave embedded on top of it. It's an anterior to posterior dipole, negative at the back. The anterior positive is usually a lower amplitude. So again, just like the cervical horizontal dipole, same generator source. Maximal and amplitude at the level of T12 typically. Frequently used as a reference for measurement of central conduction in the spinal pathways. So just like we're using cervical to cortex for those central conduction times during carotid endarterectomies, the diagnostic world will use this T12 to iliac crest or the lumbar potential to the midline cortical lower extremity SSEPs, especially in cases of multiple sclerosis or some kind of tumors or something like that, where they're looking for disruption of the dorsal column. Represents postsynaptic potentials generated in the dorsal horn of the spinal cord at the level of the conus, analogous to the stationary N3P13 potentials recorded over the neck with stimulation of the median nerve. So again, here we are with montages that look a little bit more familiar to us. Maybe the pop fossa response, we all should be kind of familiar with that, distal to proximal. Here's that lumbar potential with the negative peak at the top here, very similar to our N13. Here's our far field response, this FPZ to cervical. Please note, I know people that have a 16 channel machine might be running out of free channels to use, so they might use a C5 to FPZ, which is the same thing as what we use for a cervical response, but the cervical area is isoelectric or completely inactive in a lower extremity SSEP, so that makes it a very poor area to
use as your active electrode. The cortex, most notably the frontal area of the cortex, is the hotspot for these generators of the P31 and 34. So you will get a much better response if your active electrode is over somewhere on the cortex. Usually the frontal lobe is the best area, and then reference that to some non-cephalic area. You can do Erb's point, you can do the hand. Most people just use the cervical channel because that is already placed in most cases. And then we look here, we have our CPI, which is the ipsilateral side of stimulation to FPZ, has sort of the smaller wave compared to the midline CPZ to FPZ. The additional channel that you would use would be CPI to CPC, which would be the ipsilateral to the contralateral, and then you could also use CPI to CPZ. Sometimes that does not have enough difference in the polarity, and you won't get a good enough response. Other times it has a very beautiful wave. This is our lumbar potential showing the greatest amplitude at T12, at least in this patient. P31, the FZ, reference to the cervical spinous process of 5. It's a far field positive response. It is isopotential at FPZ, FZ, CPZ, C3, and C4 must be referentially recorded because of an in-phase cancellation of P31 and N34. That in-phase cancellation happens when you have a cortical to cortical bipolar setup. You can see that's the amplitude here, and it's isopotential. It's in-phase cancellation because it cancels out from the two different recording electrodes. It's analogous to the median nerve somatosensory evoked potential of P13, not affected much by anesthesia. Vertebral basilar artery supply is the vascular supply. It's linked with N34 because it's picked up on the same recording, and it's an obligate peak. So again, here we have our pop fossa. We have our subcortical. This is our P31, comes in at 29 in this patient. N34 coming in at 33 on this patient. And then we have our two cortical channels. I would say this is probably pretty representative of what most people are running for lower extremity SSEPs. I choose to add in one, maybe two other cortical channels. If I have one or two that are just completely garbage, then I'll just get rid of it and just stick with the two good ones. Here's a picture showing a normal left posterior tibial somatosensory evoked potential recording using a spinous process of C5 as the reference. These are all cortical areas as the active area, and we see this far field P31 N30 response. It's capable of being recorded anywhere over the cortical area. I've seen papers that have shown that the frontal area is even better, an area to get more representation, especially from the N34. And we see this CZ gets the largest cortical area because that is the midline area, which is closest to that near field potential of that cortical area. The N34, which is also the FZ to C5 spinous process reference, generated subcortical response. It's analogous to the N18 following stimulation of the median nerve. It may reflect postsynaptic activity from many generator sources in the brainstem and perhaps thalamus, very closely related to P31, a far field potential, and anesthetic resistant. So here again is our P31, comparing it to the N34. This is electrodes placed along the dorsal aspect of the brainstem, having very similar responses from both the lower PTN and the upper median nerve. And you can see that this is a stationary response because as the signal travels up, if it was a traveling response, it would change in latency, but we can see it travels right along the same latency for both the P31 N34 and P14 N18. Cortical channels, the P37, sometimes called P39, sometimes called P40.
The most common ones is CPI reference to FPZ or CPZ to FPZ, that midline channel. It is an obligate peak. The foot area in the primary somatosensory cortex. Potential is usually maximal somewhere between the midline and the central parietal scalp locations, contralateral to the stimulating leg. That's the normal physiological area that is stimulated when you stimulate the lower extremity. The primary component may consist of at least two dipoles. Now here's the twist. Because the orientation of the dipole inside the longitudinal fissure is variable, the P37 is sometimes maximal or highest amplitude over the ipsilateral scalp. This is known as paradoxical localization. That is a term that you need to know, paradoxical localization. It deals with the fact that the dipole within this curved sulcus, so here we have the lateral area for the where the hand might be, and that's the direction of the dipole. Because we have the turn of the brain as it goes medially and down deep, it has about a 90-degree turn. We have a difference in our dipole orientation, and because of the areas of the sulci that are invaginating medial to lateral, it again changes the possible orientation of this dipole, which is why it is necessary to have both a midline and a lateral cortical channels being monitored throughout the case. It should be used both the ipsilateral scalp as well as from the midline. Okay, just like I said, it's an obligate peak. It is a near field potential. It is markedly affected by anesthesia. It is affected by a high rep rate. The anterior cerebral artery supplies it. Remember, the anterior cerebral does the whole midline area. It's the bipolar montage setup subtracts widespread far field signals, and it's the end of the central conduction time in the lower extremity coming from starting at the lumbar potential. Now remember that this is a near field response, and the response is coming somewhere down here in that middle gyri, which increases the distance between your recording electrodes and the generator potential. So that is one reason why lower extremity SSEPs are more difficult to obtain and less reliable typically than the upper extremity. Of course, the other being the peripheral neuropathies that's becoming rampant in our population, and the fact that it has to travel a lot further distance going through the whole lumbar and thoracic area as well as the cervical area. So it has a lot higher probability or more chances of being impinged upon or some kind of conduction block creating a poor signal, as well as the distance itself being longer. It has a lot. So the way we collect SSEPs is they are time locked. So if we stimulate the fastest conducting axons, they all should come in right around at the same time, but they all might have slight variabilities in speed, and those variabilities in speed are brought out the longer the distance it has to travel. That's the whole thing where if it's a 5-yard dash, most people, there's not a whole lot of difference, but if it's a 50-yard dash, you'll see the difference in speed. So the same thing with the SSEPs, which is very reliant upon this averaging of the same wave over and over again, where this long distance makes that difficult. So there are students asking, what was that in-phase cancellation stuff that you glossed over in that previous couple slides? So here we have far field potentials and in-phase cancellation. The referential or hand and bipolar derivations of the scalp and neck potentials following the posterior tibial nerve stimulation. The bottom channel reveals a low amplitude P31 and an unlabeled N34 following the P37 cortical amplitude. The N34 is greatly attenuated in the scalp-to-scalp derivation of the CZ to FZ, and in some individuals is absent. The P31 and N34 are far-field scalp-recorded events that largely cancel by in-phase common mode rejection and scalp-to-scalp derivations. The neck-to-hand, or the C5 spinous process to the hand, derivation shows essentially no potential indicating that there is little recordable activity over the cervical area. The C5 spinous process is effectively an inactive non-cephalic reference for lower limb stimulation. So like I said before, if we come up and look at this cervical active area, there is no far field potential because it is an inactive area. But when we have the FZ as the active, we do have some far field potential here. Temperature changes. Hypothermia is when your core temperature drops below the required temperature for normal metabolism and body function, which is defined as 35 degrees Celsius. So that's a pretty important sense there to remember. Body temperature is usually maintained near a constant level of 36.5 to 37.5 degrees Celsius through biologic homeostasis and thermoregulation. So that's a typical range that we jot down when we go and look at our anesthesia to take notes. The lower extremity SSEP equals 1.15 milliseconds per degree Celsius increase in the P4 latency. So it's slowing down by 1.15 milliseconds for every degree Celsius that it gets colder. And we can see that in this picture as we decrease in temperature, so out goes our cortical channels. Can you go over some of the components of the equipment and how that improves the collection of SSEP data? This is probably one of the more difficult areas for people to understand. They will ask questions on it. A lot of people get it wrong. Hopefully, some of this will stick, and I'll try to highlight some of the most important parts of it. So signal averaging is the number of trials that you have in order for these evoke responses. Here is our guidelines again. The ACNS is 250 to 1,000, where the SNM is 500 to 2,000. And we'll get to where they came up with those numbers when we start to look at the signal-to-noise ratio. But first, averaging involves 3 steps. Repeated stimulation of the evoked potential, storing and adding those evoked potentials, and dividing the sum of the total number of responses. So if we come and look over to the right, we see that we have 3 traces that are combined with signal and noise. The 3 of those look barely the same, except there's one cortical or subcortical, whatever we're recording from channel, that is consistent in all those waves. When we add those 3 together and get rid of all the non-consistent factors, we have this leftover cortical channel. If we took out that cortical response and we're looking at just pure noise, we would add those all up, divide it, and because there is no consistency in any of the waveforms, we have an isoelectric potential. The problem with artifact that is consistent, like a 60 hertz or 120 hertz, is that can sometimes repeat over and over again, and when we go and we average those traces out, it still might infiltrate our potentials because it is collected in enough recordings that it does not average out. So signal averaging in itself enhances the response if each stimulus produces neurosignals that is consistent and time-locked, while most other neuronal activity is random. If we look at our EEG, that's just kind of random potentials. All the stimulation is constant from potential to potential. The background noise has a mean value of approximately 0. Random noise from EEG, EKG, muscle artifact, etc. The activity from the stimuli isn't related to the ongoing spontaneous activity. When the signal is large and the noise is small, few responses are required. That means it has a better or higher signal to a lower noise ratio. The averaging process results in a marked improvement of the signals to noise ratio, in which the noise reduction factor can be estimated by calculating 1 over the square root of n, where n is the number of stimuli delivered to evoke the average. So if you have a huge honking amplitude, such as a motor evoked potential CMAP response, you don't even have to do any averaging. You can just do one signal, collect that trace, and then you know that the noise is not going to interfere with what you're looking at. If you have a very teeny tiny response like an ABR, you have this much larger noise that can override it and sometimes mask it, where you need to do a lot of traces.
So the signal to noise ratio is dependent upon the size and frequency of the noise, but also very dependent upon the amplitude size of the potential that you're recording. So again, this is why if you read my website, you see that I really make sure that you're trying to do your best to optimize all signals so you get the largest signal representative of that generator point in order to have a better signal to noise ratio, in order to have a more reliable waveform to make judgment calls off of when surgical or metabolic problems happen. The number of trials times the rep rate is what we're going to look for to make sure that we have enough signals to average out a good evoked response. So you can find out how long it will take to obtain these evoked potential responses by taking the number of trials and multiplying it by the rep rate. So for instance, if you take 500 traces, which is the fewest recommended by the ASNM, by a rep rate of 4.13, which is well within the ACNS guidelines of 2 to 8 reps per second, also recommended by the Cadwell as a rate that best gets rid of the 60 hertz noise. If you use a Cadwell, please look in the help section. It has a very nice diagram where it gives you actual rep rate numbers and what frequencies that they are very well at getting rid of. 4.13 happens to be on that chart that gets rid of 60 hertz. If that doesn't work, I can find a slower rep rate that also gets rid of 60 hertz and try that out. If that doesn't work, I can see if one of the other rep rates that gets rid of some other common frequencies found in the OR, like 90 or 120 or 180, and test those out. So it's not just looking for something that's an odd integer or not an integer of 60. It's not just something that's less than 5 hertz, but there are specific numbers that will have better effect at getting rid of the most common noises that you'll find. So back to the equation. So then if you take 2 minutes to get a response, or 500 traces, divided by 4.13 reps per second times 60 seconds in a minute. If your filter settings are tight, your impedances are low, and you've done everything you can to reduce extraneous noise, you might be able to record reliably with less traces. So 200 to 300 traces only needs about 1 minute if you're still at that rep rate of about 4 reps per second. If the noise is too great, you may need to sacrifice speed by collection of reliable waves. Going from 500 traces to 1,000 traces increases the time to collect by 2 minutes, or doubles the time of acquisition, but reduces the noise by a factor of 1.14. And you can find that out by finding the square root of the factor by which the number of sweeps increases, or it's equal to the square root of 1,000 over 500, because we went from 500 to 1,000 traces, or it's the square root of 2, which equals 1.41. Now, if you're not used to that math, this is the time to pause the video. I'll have some other on the next slide also, but just change those traces around a little bit. Go from 100 to 500 and see what that is. And you'll see where you're getting the most effect of by this factor. So again, here we are, a little bit more math. We have a nice cortical SSEP that is around 3 microvolts. That's a pretty big amplitude, but noise that is coming in at about 50 microvolts. So that's kind of close to EEG activity. That signal to noise ratio is about 0.06, and we found that by doing the 3 microvolts divided by 50 microvolts, or our active divided by our noise. We need to multiply it by 16.5 in order to get that signal to noise ratio close to 1. So all I did was we had that 0.06 times x equals 1, and then I found out that x equals 16.5, and we call this the suppression factor. That's the term. So if we take the square root of the number of trials equals our suppression factor of 16.5, our n is 272 sweeps. So that's the number of sweeps or trials that we need in order to make sure that we have a very good, reliable trace. If we want to improve the trace a little bit more, say to a ratio of 1.5, then we need to figure out the suppression factor and go from there. So here we have 0.06 times our suppression factor of x equals 1.5 ratio. X then equals 25. We find the square root of the number of trials equals 25, and we find that we need 625 traces in order to get a suppression factor, or in order to get the ratio to 1.5. If we decide that's too long to average the response, we can see what kind of improvement we'll get if we go from 272 traces to 500 traces. So this is, again, just working the equation in a different direction just to make sure that we understand it. So here we have the square root of 500 traces going down to 272 traces, so we divide 500 by 272, and that equals x. That 500 divided by 272 is 1.8. The square root of 1.8 is 1.3. So that is the new ratio that we have achieved, is 1.3. And then you can check your work by working it backwards. Analysis time, or the amount of time that you put on the screen in order to analyze your evoked responses. Recommendations from the ACNS is 40 total, 50 total for the SNIM. Actually, that's for the uppers. So I have an upper extremity here. Even though this is the lower extremity, I just found an upper extremity picture, so that's what we're going to go off of. But here we're defining analysis time more so than looking at a lower extremity analysis time. The analysis time for the lower extremity, according to the SNIM, will be at 100. So on this picture here, we see the on the green one where we have the amplitudes, we have the time period between each waveform that we're looking at, and we have a peak-to-peak voltage. So that is some terms that you might be asked to look at. If we're looking at the Cadwell trace on the bottom of the page here, and we were asked what is the analysis time, we can look at the bottom right-hand corner, and we see that we have 5 milliseconds per division, 10 divisions on the screen. We're at 50 milliseconds total. That is our total analysis time. What is the onset latency of CP3 to FZ? Here we look at either the number of boxes where we see the onset generator peak, or we can see that it's already labeled with the crosshair at 25 milliseconds. Right there. What is the amplitude of the CV to FPZ? So here we are looking at the, the cervical channel, latency of 17.5, amplitude down to 20.09, that's the duration of the amplitude, with a 0.44 microvolt amplitude size. If we look down at our divisions this way, we have 1 microvolt per division. If we were just eyeballing this thing from here to here, we'd probably say it's a little less than half. And since we have the crosshair markers, we have an exact quantified number of 0.44 microvolts. What is the duration of Erb's point? So here we have an onset latency of 12, the end latency of 16.3, the amplitude size is 2.43, but if we take this latency subtracted by this latency, we get 4.3 milliseconds as the duration of Erb's point. What is the central conduction time? Here we find the onset of our cervical, which is 17.5, to the onset of our cortical, which is 25, and the difference between those is our central conduction time, which happens to be 4.1 milliseconds. Pulse width, 100 to 300 microvolts, or I'm sorry, microamps. When we look at the pulse width, we use that in connection with our intensity, and the output of that is called power. So if we have an ideal setting, if we have 20 milliamps and we have a 100 microsecond pulse duration, that's exactly equal to 10 milliamps or 200 microsecond pulse duration. But if we look at the chart on the right here, this is a hypothetical curve. It's somewhat factored correctly, but there's a lot of different variables like impedance and some of those other things, where if we look at the duration, we lose the power output, the higher up or the more or the longer the duration we use, and it really becomes less effective after about 0.3. So I know some people, when they're stimulating, they like to do a nice long pulse duration, say they'll crank it up to 0.5, but you're losing the power output efficiency of duration. One of the side effects of power output, especially with duration dependence, is heat. So if we're looking at a risk of burns, the longer the duration of stimulation, the more heat production, the more likely for burns. And that's why we have a lot of regulations on things like motor evoked potentials or some of these other high intensity outputs that we use in order to make sure that we do not have too long of a duration, too much heat given off, and too much risk for burning the area. So pulse width and intensity are inversely proportional up until a point where increasing the duration affects the power output very little. The duration of exposure to the current is also important because the longer the pulse widths are, the higher the risk for occurrence of burns or cardiac arrhythmias. Subcutaneous skin can act as a capacitor, which charges and discharges with every electrical pulse. The greater the pulse width delivered, the longer the discharge of the capacitor. This leads to a larger capacitive skin artifact. Stimulation rates that have been given by RASNM and ACNS. That's our guidelines as far as how high we can go. But when we look at some of the noise, we have 60 hertz is the most common noise artifact in the United States, while 50 hertz is the most common in the UK. That's been a question on previous tests. Choose a stimulation rate that is not an even number to prevent overlap with the common noise frequency. So remember the signal averaging. In the upper extremity, you will get amplitude degradation if your rep rate is over 9, 5 in the lowers. So here we're looking at the most common frequency of hertzes, 60 versus 50. We can also see why we don't want even numbers or integers of 50 or 60, because this 5 happens to be both. And look at that, you have a nice inline area. If that was an average or an evoked potential that you were actually trying to record, you would have terrible noise ringing over that, and you would not have a reliable waveform. Stimulation intensity. Although intensity-dependent changes and the responses are present at stimulus levels below motor threshold, there is a change in amplitude or latency of the response once the stimulus is above motor twitch threshold. So there's our 3 guidelines: stimulation intensity 30 to 40 milliamps, stimulation intensity till Erb's point or pop fossa amplitude no longer increases in size, or stimulation intensity twice the motor threshold, which is usually around 6 to 10 milliamps. Impedance checks should be less than 5 kiloohms for both stimulating and recording electrodes. Impedance, in its very simplest terms, is resistance occurring in the AC electrical circuits. The degree of resistance is measured in a unit known as ohms. The lower the impedance, the easier it is for electricity to flow through an object. Keeping the recording input lead short and the electrode impedance values at 5 kiloohms or lower for gold disc or subdermal electrodes will help to minimize the amount of stimulus artifact and other electrical noise that is recorded. To minimize discomfort, contact impedances of 5 kiloohms or less is recommended. If impedance levels fall below 100, there may be shunting due to a salt bridge when 2 electrode paste of 2 electrodes come into contact. Inspect those electrodes. Again, this is one of those questions that is no longer a problem because we don't really use these paste anymore for our stimulating electrodes, but from a historical perspective still seems to find itself on the CNIM. So you do not want an impedance below 100 for your stimulating electrodes. Can you name me 4 variables that you must consider when using electrodes to stimulate? Sure, you just went over them. First is intensity. Using constant current, this is kind of a review here. When we use constant current, we are stimulating with milliamps. Constant current stimulation varies the stimulus voltage in order to ensure that the required and requested current is delivered at each pulse regardless of change in skin resistance. We really shouldn't need to go over 40 milliamps, though up to 100 milliamps has been used. using twice motor thresholds, or finding the intensity where a peripheral response no longer grows in amplitude, plus 10% or so as a guide for that supermaximal intensity, we should be able to find a safe and effective level of intensity. The duration. This one can really cause burns or pain at the stimulation site if not set right. 100 to 300 microseconds for pulse width is recommended. Again, there are times when you might choose to go up a little bit higher. One of those that seems to work out well is when we do saphenous nerve SSEPs in the lower extremity. Frequency. Similar to duration, too fast of a frequency may cause problems locally. It may also cause amplitude degradation, which may cause you to increase the intensity or the pulse width instinctively. This happens at a rep rate of 9 in the uppers and 5 in the lowers. Staying between a rep rate of 2 to 5 allows for fast, reliable, and safe acquisition of the data. Impedance. The lower the impedance, the easier it is for electricity to flow through an object. Shoot for an impedance between 1 to 2 kiloohms, but under 5 ohms or 5,000 ohms is our goal. Anything higher will cause a need for more power to achieve the desired results. That's if you're doing a stimulation from there. Okay, so now we are going to talk about some of the filters and what we're allowing as far as frequency and amplitude size of noise versus evoked responses to allow to pass through our filters. So first is our bandpass settings, a low cut of 30, a high of 1 kilohertz with a amplitude of -3 decibels, or to say differently, a low cut of 30 hertz and a high cut of 1000 up to 3 kilohertz if trying to record the P14 response. That's from the ACNS. The ASNM guidelines is 30 to 100 hertz to 250 to 3000 hertz for corticals, and 30 to 100 for the low cut up to, and then 1000 to 3000 for the high cut hertz for subcortical, and that's the ASNM. Filter rolloff should not exceed 12 decibels per octave for the lower frequencies and 24 decibels for per octave for higher frequencies. So from this slide, just put those numbers to, just put them to memory. They're testable questions, and these later slides I'm going to try to explain them a little bit better. Appropriate settings for analog filters is important to optimize the evoked potential recording of interest by effectively reducing artifact and unwanted signals and improving the signal-to-noise ratio. Narrow band filters minimize artifact contamination and allows for faster accumulation of samples by reducing rejection. So here we have our first definition. Here is our bandwidth. This is the area of frequency and amplitude of potentials that we are going to allow pass through our filters and use in our collected data. Everything less than that, we would ideally eliminate. Anything greater than that, we would ideally eliminate. But because our filters are not 100% efficient, we see this sloping area where we get to a point where it's pretty much gotten rid of it. But we still have this other little area here where a certain percentage of those higher than wanted amplitudes or faster or slower than wanted frequencies will get through. And that is our slope. And we'll get into that a little bit more here. So some other terminology is pass band is the same as bandpass is the same as bandwidth. So they can use those three terms interchangeably. So here we see pass band. These are all the frequencies that we want to collect and record, also called bandpass and also called bandwidth. A low frequency filter or a high pass filter, those are two interchangeable names, reduces the amplitude of slow waves without attenuating fast waves. So here we have our high pass or low frequency filters. It's always on the left side here. And then here we have our transition band because we have an inefficient slope. So it is allowing the passage of all high frequency activity, but it is a low frequency filter, so it's filtering out the low, slow frequencies. Complete opposite for a low pass.
It's allowing all the slower speed ones to pass through and getting rid of all the high frequency stuff. And then here is our roll-off and slope, which we will get to here shortly. Transition band is the area between the pass band and the stop band. Data is still collected here, but at a lower percentage. So here we have our pass band, here we have our stop band, and here is our transition area. Roll-off is the steepness of the transmission function with frequency. It is measured in decibels per octave. So beware of these these AKAs can be confusing. A high frequency filter removes high frequency components above a certain cutoff point. So in this picture here, anything above 20 Hertz is filtered out, but it is allowing this low pass or these lesser frequencies to pass through. But wait, it's not a perfect system. Filters are electronic components made up of resistors and capacitors and require time to discharge. Instant changes are not possible. There is a smoother, gradual change that happens. The guidelines state, with filters wide open, the amplifier bandpass measured at -3 decibel points must be at least 0.1 to 5,000 Hertz, so a roll-off has to be selected accordingly. When using a 3 decibel amplitude attenuation, it is locating the frequency at which the amplitude has been reduced to about 70% of the original value. So here we are finding this 70%, and that is the cross point here at this -3 decibel point amplitude, which is, oh, I'm sorry, this scale is using -6 decibels per octave in this example. Roll-off filters. Low and high cut filters are resistors and capacitors, or resistors and inductors. This simple filter with passive components is known as the first order filter. It has a roll-off of about -6 decibels per octave, and this -6 we'll see is a recurring number. This means that the signal strength will cut in half each time the frequency doubles. So for a high cut filter set at 1000 Hertz, about half of the signal amplitude will be present at 2000 Hertz and a quarter at 4000 Hertz. Analog filters with active components greatly improve the ability to exclude frequencies outside the bandpass. A second order filter has a roll-off of 12 decibels per octave, a third order has -18 decibels per octave, and a fourth has a -24. So all you have to do is find out what order it is, multiply that by 4. And here we have that written out here. It is recommended that a low pass filter have a roll-off of at least -12 decibels per octave, or a second order, and a high pass filter have a roll-off of at least -24 decibels per octave, or a fourth order. Here on this chart we see 6 is red, 12 is this orange, and 24 is green. We can see how much more effective a 24 or a fourth order roll-off is compared to the 6. The 6 is allowing for a lot more transition zone and allowing a lot more unwanted artifact frequency noise. So if we're using both a high frequency filter and a low frequency filter, then we can find the sweet spot, which is what we call our bandpass or bandwidth or pass band. Our low frequency filter removes frequency components below the above certain cutoffs. So it's filtering off this slow stuff. The high frequency filter frequency out this high stuff, and we are collecting hopefully everything between 20 and 250 Hertz. We have this roll-off sloping here, which this should be -12 decibels per octave. This should be -24, or the fourth order, second order, in order to most appropriately collect what we're trying to collect. Okay, so now we have a picture here. The green is the fastest frequency, and it is something that we do not want. The purple or pink is the
evoked response that we are trying to collect. The blue is the slowest waveform that we also do not want. It is also noise. If we do not have any filters on it, we have this unusable polyphasic response that's given and collected. Now we add a low pass filter, so we are allowing everything that is slower than a certain frequency to pass through. So we are eliminating the fastest, this green one, which is now iso potential and it's not affecting our waveform. And here we have something that is more similar to the pink wave that we're trying to collect. The high frequency noise is not contaminating this waveform, although we can still see some contamination from the slow wave artifact. The high pass filter is going to do the opposite. Again, here we have the unfiltered, looks exactly the same as the last slide, but now we get rid of this slowest blue wave because of our high pass filter, allowing all the faster frequency stuff. So what we're left with is this green high frequency noise and the purple or pink evoke response we're trying to collect. Again, this looks much more similar to what we are expecting to get in this pink or purple trace, but the low frequency noise is not contributing to this waveform, although the fast frequency is. I don't have a picture of it, but obviously the high and low pass would have something very similar to the purple or pink line. Can you change filter settings during the middle of the case as you encounter different forms of noise? That sounds like a trick question. Are you looking for an answer on the CNIM, or are you answering from my new IOM machine? So we have to make sure we know what we're talking about when we're playing around with these settings on our equipment. When we're talking about analog filtering, if we change it after we establish baselines, then we change our analog high pass or low pass frequencies, we can have what's called a phase shift. Filtering causes a change in phase or shift, a time delay frequency component as it passes through the filter. It may cause waveform distortion, especially if the shift occurs near the cutoff frequency. So the closer to our settings of our filters, the more effect it's going to have on our waveform. Conventional machines use analog filters made of resistors and capacitors. Analog filters alter not only the amplitude, but the relative timing of individual waves in a signal, and I'll show you that in the next slide. Low frequency filters affect mainly slow waves and make them appear earlier than fast ones, while high frequency filters attenuate fast components and make them appear later than slow ones. This effect is called the phase shift and is more prominent at frequencies near the cutoff. New machines allow for digital filtering that mimic analog filtering but do not cause this phase latency shift. So if you are going to make changes during the middle of a case, you want to make changes to the digital filtering, not the analog filtering. The ratio of high to low frequency filter settings should be at least 100 to 1 to minimize this phase shift, and that is just the number you have to commit to memory. So questions that have been found on previous exams look something like this. If you lower the number of high cut filter settings, then the peak latency becomes longer or has a phase lag. You have to know that term, phase lag, or it shifts to the right. So out of those things, you have to know what filter we're talking about, how we're affecting it, and where the waveform will shift out to. The opposite is seen by increasing the number of low cut filter settings. The peak latency shortens, or called phase lead, again you have to know that term, or shifts to the left. So phase lag versus phase lead, be able to discuss that and know each three parts of it as it corresponds to the high and low filters. So effects of filter changes. On the left side we have effects of a low cut filter. We are starting at 10 Hertz and going up to 1 kilohertz. This diagram is not showing too much of the distortion of the phase lead, but it is showing a little bit of the amplitude changes. Now, if we look at the 1,000 or 1 kilohertz amplitude, that dotted line is slightly to the right.
If we look at the 10 hertz, it is slightly to the left. So it's kind of hard to see, but when you look at the top versus the bottom, you can see that there is a change in the latency. It is a little bit more prominent on this effects of the high cut filter, which also has a lot larger change to it. And we can see it just shifting out, or that phase lag that is happening. Why are there different ranges for the filter settings of a peripheral response versus a cortical response? So there's a different level of signal to noise ratio depending on where you're recording. For example, the N13 in the upper extremity is a near field response, so it has very little noise contaminating the time lock potential at that cervical spine. There's a difference in the frequency and duration in the waves collected. You need to choose a bandwidth or bandpass that is appropriate for the setting of the potential being collected. Too narrow and you eliminate useful components by decreasing the amplitude. Too wide a bandwidth and you are susceptible to noise contamination. So how do you feel about using a notch filter for SSEPs? Does it eliminate noise in the bandpath we've selected? So if we look at a notch filter, the cutoff points are around 60 hertz, but degrade actively in the range of 47 to 78 hertz, so that all frequencies in between will be severely attenuated. So again, the notch filter is not a completely efficient filter. It has this roll-off and it has a wide range and different proportions, but it has a range from 47 to 78 hertz. The 60 hertz ringing artifact associated with stimulus artifact or any other large amplitude transient. It consists of rhythmic sine waves with progressively smaller amplitudes following the stimulus artifact and may mimic a true response or obscure the short latency components. This is time locked and will not average out, which makes it one of the more difficult noises to get rid of. This is problematic in evoked responses like SSEPs and bears, since they have stimulus artifact but will not have a problem with visual evoked potentials. So that's one you have to know there. Because there's no stim artifact with VEPs, you don't have to worry as much about it. Interleaving potentials to increase recording time. Early SSEP acquisition was done one limb at a time. Newer machines are able to stimulate multiple limbs individually by interleaving the stimulation. Some argue that using a bipolar stimulation may lead to miss a unilateral change. Others suggest using bipolar stimulation if there's no reliable data or smaller amplitudes when using interleaving stimulation. So this whole interleaving is something that came, if you're new to the field, it's something that came back as the machines got better and better. Before you could only do your left lower and then you collect and store, then you do your right lower, collect and store. So now we're able to stimulate all of them at once by using this interleaving pattern. As the machines hit their next phase, they allowed you to stimulate both at the same time as well. So if you have lower extremity potentials that are unreliable, one troubleshooting way that you could use is by stimulating them both at the same time. Because the lower extremity cortical areas are so close together, you now have increased your chances of being able to record something that's time locked. You lose out on your ability to tell if it's a right side or left side deficit, but at least you're recording something at that point. All right, and that's it for this section. Just a reminder, if you have questions on this, on any part of this, the best place to put them is on the forum. I will check there periodically, and hopefully we have other active members. So if you have questions, please put them on the forum. If you do some further study and you'd like to add to the community, please add it on the forum as well. That's helpful for everybody.